Hello everybody, my name's Liz Brooke and I'm primary care pharmacist at the PDA. It gives me great pleasure to introduce Alima Batchelor, who recently joined us as Head of Policy. And she's going to talk to us today about appropriate working conditions for general practice pharmacists.
Thanks, Liz. Hi everybody. So I'll do a little bit of history for me. I've been working in pharmacy for a depressingly long time, over 30 years now, and have experience in retail, hospital, primary care, and as Liz said, I've been with the PDA for 4 weeks. So I'm going to give you my take on how I feel practice pharmacists should be supported, and how we need to use this really valuable resource going forward in the NHS. So by the end of the presentation, I'm hoping that you'll know a bit more about the variations in funding levels, focus, employment patterns for clinical pharmacists in GP practices, because there are initiatives going on across the UK, but they differ slightly depending on which country you're in. Also, some emerging concerns about working conditions for practice-based pharmacists, not all, but some. And finally, some of the proposals that the PDA is looking to make to try and ensure that when we do have clinical pharmacists in GP practice, they can provide a truly professional and effective service, something that all of our patients need. So a little bit of history. As I'm sure some of you will be aware, having pharmacists in GP practices is not new. Some pharmacists have been there, some trailblazers from the early 90s, and then primary care groups started to have a look at medicines management, and they had usually one pharmaceutical advisor each. This then moved on to primary care trusts, which were bigger NHS organisations, and they had heads of medicines management and a small medicines management team. And then clinical commissioning groups, which were smaller again, who had a team which sometimes then had technicians as well. And I would say through all of that time, the independent pharmacists that have been working in GP practices were doing a number of different jobs. A number of them would have independent prescribing. From the early days, some of them were offering anticoagulation clinics. They do a lot around management of long-term conditions, and quite often they'd help their GP practice to ensure that they got as maximum quaff points, or certainly the pharmacists that I spoke to mentioned that as one of their key duties. Looking at the CCG teams, they often had embedded pharmacists working in the GP practice, but then also pharmacists looking at care homes. So they would be going around providing a service to local care homes, looking at both the systems for managing medicines in the care homes, but also doing clinical medication review for residents of the care homes, since they're a well-recognised group of patients who simply don't usually get enough pharmaceutical input to make sure that their medicines are suiting them appropriately. Looking more recently, I don't know how many of you saw Duncan talking earlier from Dudley CCG, but CCG started to employ more pharmacists who had independent prescribing qualifications. And there's been quite a lot of exciting work going on there. Looking at Dudley, they did a harms project, and that was looking at hospital admissions related to medicines. And I think the hope is that that work will be published quite soon, and so they were looking for markers of risk to do with risky medicines, so things like methotrexate, things like ACE and ARB inhibitors. Are these drugs being monitored properly or not? If they're not being monitored, let's get the blood tests ordered and let's act on the results. In Walsall, again, they have had practice-based pharmacists for quite some time, some of whom are prescribers, and they had a project where they put them into practices for 1 or 2 sessions a week to manage their repeat prescribing, in some cases taking on full responsibility for a particular group area of prescribing, quite often to do with things like home care delivery companies and managing the orders for nutrition, and other drugs, stoma, catheters, catheter bags, and making sure that these orders were managed effectively and that there wasn't any waste. They also did make clinical interventions, and the results again were quite good. I know that from the finance point of view, Walsall could claim that they had a return on investment of £3 for every pound which was invested in employing pharmacists. And looking at Scotland, I think they really are ahead of the curve. In 2013, they published something called Prescription for Excellence, and this looked at practice-based pharmacists and had an aim that they would have pharmacists with clinical skills in every practice. In 2015, NHS England decided that they would they'd look at pharmacists in GP practice, and they published the GP Forward View. They did a pilot phase, which was just under 480 pharmacists across 600 or odd practices, and then the rollout phase, which they're in now, and it's looking at getting 1,500 pharmacists by the year 2020. So that's quite a significant increase. In Northern Ireland, slightly different, but again, they're looking at putting in practice-based pharmacists, but at GP federation level. And in Wales, they're doing things really quite differently. So what they're saying is to their practices and their health boards, we want certain outcomes for patients. Here's the money. You decide how you get those outcomes. And in some cases, that means that they're putting more clinical pharmacists in GP practices in Wales as well. So here's a picture of the Bay medical team. And I don't know if any of you saw the article in the Pharmaceutical Journal recently about how they work, but I thought I'd put a picture up. I just liked the way they looked so happy in their work. They have a team of 6 pharmacists, 3 senior technical staff, and then 8 medicines management operators. And they basically manage all of the repeat prescribing for a group of practices with 65,000 patients. So they do everything from looking at letters for patients coming out of hospital to dealing with patient requests to providing advice to their GPs on formulary and interface prescribing issues. And I find that a really attractive model and could see that working quite well. And think it needs to be certainly considered when we look at how we move forward in the elsewhere in the UK. So, as I said, general practice forward view. I thought I'd do a couple of quotes, or a few quotes now. In April 26, they said that pharmacists remain one of the most underutilised professional resources in the system, and we need to bring their considerable skills more into play. So they're putting pharmacists into practice. They've done a little bit of review of what's going on, and they've said that their early indications from the pilot and looking at the early waves suggest that clinical pharmacists may have a role in streamlining practice prescription processes, medicines optimization, minor ailments and long-term conditions management. And I have to say, none of that seems hugely surprising, I would say, to any pharmacist. It would seem like common sense that we would have a role to play or could confer some benefit in those areas. In NHS Scotland, they've got quite an extensive primary care fund to put pharmacists into GP practices, and they say that it's intended there'll be a nominated lead pharmacist in each board. Now, to me, that's their equivalent to the CCG, so they're definitely involving NHS medicines teams in overseeing some of the process that they've got in place. So they feel that those senior pharmacists should oversee the development of GP pharmacists, and that they would be able to liaise with NHS Education Scotland to support both training and development, not only when the pharmacists first go into practice, but ongoing for their CPD and career development. They updated a prescription for excellence in 2017 with the latest document called Achieving Excellence in Pharmaceutical Care. And they say that pharmaceutical care consists of a number of components, but at its core is that you play to the strengths of pharmacists and pharmacy technicians and other pharmacy support staff, and that we need to unlock the capacity in an incremental and structured way, because that's the only way that you can ensure that you will achieve the strategy that you want in the long run. So I thought I'd do a little quote. This is from Professor Linda Strand from America. And they, I think, coined the phrase pharmaceutical care some years ago. And what they look at is having well-trained clinical pharmacists who actually hold a caseload of patients with long-term conditions and manage them through their medicines treatment. And they say that pharmaceutical care focuses the knowledge, responsibilities and skills of the pharmacist on the provision of drug therapy with the goal of achieving definite therapeutic outcomes. So it's not really about have you prescribed in line with the formulary or how much money can you save by swapping atorvastatin to simvastatin. It's looking at individual patients, looking at their medicines, looking at their blood tests, discussing any potential side effects and agreeing objectives for how they might need to change their therapy with the patient, and then following them through. So they come back and see the pharmacist on a regular basis. In effect, the pharmacist has taken their long-term care away from the GP and reduced GP workload by reducing the burden in that way. In Northern Ireland, they have what they call a medicines optimisation quality framework. And as you can see, they're looking at the multidisciplinary team as being a basis for provision of medicines optimisation. So everybody has to play their part in the integrated team, both within primary and secondary care. I think this is a pretty good model as well. And it says that they should make sure that you utilise pharmacists' clinical skills. That's really where we've got our unique selling point. We have excellent skills to do with medicines. We can enhance those potentially with advanced clinical pharmaceutical education so that we can be the people that manage patients through the more tricky, complex and challenging medicines scenarios. So we could, in time, look after patients who are, for instance, struggling with opiate problems and drug dependence problems. We could provide the ongoing care, we could negotiate with the patients. Hopefully pharmacists would have the time to sit with the patients and agree objectives and follow patients through. This is something that there isn't really time for GPs to do at the moment, and so we have huge swathes of patients who are on medicines who are maybe not getting monitored as well as they could, and therefore not getting their medications changed or their therapy optimised. In Wales, they had their public health department look at medicines care, and they decided they were going to have a pace setter programme, and part of this, which was a strategy for the whole of primary care, was to look at extended roles for pharmacists. And they had a generalist and a specialist level. And as Duncan from Dudley said earlier on, we feel that one of the things that we need is a proper structured career pathway for pharmacists going into primary care. And at the moment in England, I think that's something that's lacking. As you can see, they said that the health boards, again, would be overlooking and ensuring that this scheme worked well and that they were making the best use of pharmacists to help patients manage their medicines. So looking at the other pharmacists, I think there's been a huge emphasis on the NHS England programme and how it is increasing the number of pharmacists in practice, but we shouldn't forget that there are an awful lot of pharmacists, some of whom have been there a long time, but some of them who haven't been there that long, but who are not part of the NHS England scheme. So PDA did a survey quite recently, and there'll be a presentation about that later on today, but one of the key things that I picked up was that 49% of the pharmacists who responded were employed by practices completely outside of the NHS England scheme and outside of any NHS organisation employment. So my question was, where or how are these pharmacists receiving senior medicine supervision, and are they getting their GP clinical supervision or not? And how are they getting their networking and training opportunities? And that sort of led me on to the next question. Well, what about CCG and CSU medicines teams? These have been around for quite a while now. Some of the teams are quite extensive. They have quite a large workforce of well-trained pharmacists, many of whom already have clinical, postgraduate clinical qualifications. They lay on training and arrange training, and wouldn't it be a sensible idea to try and link in all practice-based clinical pharmacists to these learning and networking opportunities to try and make sure that we introduce some sort of, or reduce variation in quality? So, I did a little bit of a comparison, which is a bit quick and dirty because I haven't been enrolled that long, but I had a look at funding for clinical pharmacists in GP practice. And in Scotland, for the time that they've set aside, they've covered the full cost of pharmacist salaries. In Northern Ireland, they cover the full cost for 4 years. In Wales, as I said, it's slightly different in that they've said, here's the money, you can employ who you want, just get the outcomes. In England, the NHS England scheme said we'll give you 60% of the salary in year 1, then 40, then 20. There's also, this means that from year 4, practices are supposed to find the full amount, and even in year 3, they're supposed to find 80% of the cost of the salaries. Another interesting thing is the number of pharmacists that are being employed. In Northern Ireland, they said that they're aiming to have 294 whole-time equivalent pharmacists by 2021. That actually means they've got nearly a pharmacist per practice. When you look at the NHS England scheme, currently it's going to be roughly a pharmacist per every 4 practices, and the pharmacist is supposed to cover 30,000 patients. And I suppose my question would be, how can a pharmacist sensibly and safely cover that number of practices and provide the duties that are outlined in the current recommended job descriptions? I had a quick look at the job descriptions for the clinical pharmacist, and there was a list of 21 different duties that they were supposed to be doing from, well, it just covered the whole panoply of everything a practice-based pharmacist could do, but the fact that it's all listed in a job description may well lead practices that aren't that well versed with clinical pharmacists to think that that's what they should do. And then my worry is that pharmacists are being expected to do something that lies out with their scope of professional capabilities and is also simply not sensible from a workload point of view. I'd also say, how financially stable or viable is the model as it stands in England, and will we find problems as we head towards the end of the programme and the NHS England funding starts to dwindle? And I suppose my question would be, should we be looking at more central ongoing funding for this? So looking at the entry requirements, again, there's a fair bit of variation, even down to how many years post-registration experience a pharmacist should have. I have to say, again, my personal view would be that as well as that post-registration experience, it would be sensible for pharmacists to consider a postgraduate clinical qualification. Because if you're going to be working in practice, you're going to need to be able to think about, order, interpret, and act on the results of things like biochemistry for those drugs that require it. And I think it's a bit much to expect pharmacists who've maybe not had any of that experience in hospital to come straight from retail and almost be, in some practices, expected to hit the ground running. I think that's potentially setting those pharmacists up to fail, and I think maybe we're doing them a disservice if we expect too much too early. And that's where, once again, I think we need a proper career progression and career structure for this new part of pharmacist duties. So this is a training and supervision, and as you can see, again, it varies a fair amount. And I think in particular I'm interested in what it says in the Scotland column, because it says candidates are expected to complete an advanced pharmacy practice training when they take on this role. So not just advanced clinical, but advanced pharmacy as well. And I know that a lot of our pharmacists are being asked to do or are having advanced clinical skills added into their independent prescribing. But my question would be whether that is enough of a foundation for the roles that they're going to be undertaking, because there's an awful lot to what they're expected to do. Now, I know that, again, we've been liaising with Morph Training, and Morph are laying on a whole range of training opportunities for practice-based pharmacists to try and support them in getting the skills that they need. But there still isn't any overarching strategy, or I feel there isn't an overarching strategy for exactly how we want these new pharmacists to fit into our plan for primary care as it goes forward. And together with suggested changes for remote supervision, I think we really need to maybe go back to the drawing board and look at the whole picture and make sure that what we're providing does actually give every group the tools they need to provide the service that we want for our patients. So to give you a bit of a comparison, I know that I've heard it said, oh, well, you know, it's absolutely natural that we should, with some advanced clinical skills, it's fine for pharmacists to take over a lot of the responsibilities that GPs have, and that there isn't that much difference really between the pharmacist training and the GP training. There's quite a bit of difference when you look at the clinical skills that are required. And the trainee pathway for GPs means that they not only do their undergraduate course, but then they have 2 years foundation in hospital where they'll be rotating through at least 6 different disciplines. Then they go on to the general practice specialist register, and that's 3 years of additional training, 18 months in hospital again, and then another 18 months in a GP training practice. And I've bolded the word training because I think that's really quite important. And I'd say if GPs have to be trained in a training practice, shouldn't we be wondering about where our clinical pharmacists are trained if they're supposed to be taking on additional clinical skills? At the moment, there aren't any rules about which practice will take on a pharmacist in the NHS England scheme. Any practice can, and we've had responses and queries from pharmacists, and I've had them in my old job as well at the CCG, who were very concerned about what they were being asked to do, down to someone who'd barely got the coat off. I think it was day 2. I don't believe they'd had any CCG experience, and they phoned up and said, is it all right? I've just been asked to sign all of the repeat prescriptions. And I said, no, I don't think that's all right, really. Do you feel that that's within your scope of professional practice? And they didn't, but it was their second day in the job. And I feel that that sort of thing is putting young pharmacists in a really awkward position, and that we therefore need to make sure that what we're doing meets the needs of them and also the patients, because that was a risky step to take. And my worry is that we get worst case scenario where an inexperienced pharmacist is in a practice that hasn't ever been a training practice and is just thinking, oh great, extra hours, and then we can get patient harm. So I've listed some of the concerns that the PDA or I have and what we've proposed as a remedy. We think there's a lack of an overarching strategy, and we're actually pulling together a policy document at the moment called Roadmap 2, which looks at what we think should happen for pharmacy, not just in GP practice, but going from community right the way through to the interface with secondary care, because that's where a lot of issues happen with medicines. We feel that if the practice pharmacists were tied into CCG or CSU teams, A, that would provide them with additional support, and B, that would mean that we're not actually passing up all of the experience and expertise that there are in those medicines teams that unfortunately hasn't been involved in the NHS England scheme from the outset. We do feel that GP supervision is key as well, and I know in Scotland they were suggesting there should be some form of deanery model, so there's some oversight and some checking of the training placements, and so that we can ensure that there's a lack of variation, that all of the training and supervision is to the same high standard. And we're looking at doing a document for GPs which would look at risk management for them as well when they're looking at how to take on and employ a pharmacist. So, I've mentioned lack of experience. A lot of pharmacists in GP surgeries have less than 2 years experience, so that's really not much, and we do need to try and help look at the appropriate entry criteria and also provide them with support and clinical pharmacy practice support. There are a few training opportunities that are advanced pharmacy courses now. There are about 3 in the UK so far, but we would feel that needs to be increased. And we feel for both pharmacists and technicians that we need a proper, structured career framework which is stepped and relies upon a skills and salary escalator, so that we can reflect the wide range of skills going into this discipline, but that there's also somewhere for pharmacists to go, and that as they amass their expertise and become expert, we can actually recognise that in their salary. So I've spoken about funding. If we jump down to what Tony Avery said, Tony Avery was one of the authors of the PINSA study and the PINSA trial, and he's posed what I think is quite a good question. If NHS England is serious about putting more resources into general practice and easing the burden on GPs, a more generous approach is needed to the ongoing funding of practice-based pharmacists. And he based that statement on the fact that the evidence so far shows that the bulk of benefit that pharmacists bring may not necessarily be in freeing up GP time, but is definitely in improving quality and safety. And since quality and safety is for patients is what is at the heart of every NHS strategy and the NHS constitution, should this be something that the NHS should be looking at and NHS England should be funding? So our roadmap will cover not just practice-based pharmacists, but community pharmacists as well, and try to provide that structure that can be built on, so that we can make sure that the programmes that we look at actually fit into a structure and don't just happen piecemeal and perhaps cause problems because of that. And I'm happy to take questions or comments, and I'll leave you with a couple of cartoons.
Thank you, Alima. Any questions? I've got one. Could you just sort of summarise what the difference is between what you think the difference is between pharmaceutical care and medicines management?
Well, sadly, I think medicines management, to a certain extent, ended up looking just at the medicines and just at the price tag linked to the medicines. So there was a lot of emphasis put on cost-effective prescribing, which I can understand, but the key thing is that pharmaceutical care and I suppose medicines optimisation are based around the patient. So you're not just thinking about, well, what's the least expensive way of providing this medicine, but let's have a look at this patient, let's talk to them about how they're managing their medicines, let's find out if they're taking their medicines, and let's then modify their treatment so that they get the best care and so that we have the most, we can be sure as best as we can that they are actually taking the medicines that are prescribed for them, because at the moment, as we all know, a huge number of prescribed medicines end up in the bin, and so we're spending loads on medicines and we're not actually getting the medical outcomes that we wanted. So pharmaceutical care is optimising the medicines but with the patient at the centre.
Any questions?
Hi. Hello.
Hi.
You mentioned that you felt that pharmacists should get extra clinical knowledge. Are there any courses you'd suggest if you had to say?
Well, as I said, there are about 3 advanced clinical pharmacy courses at the moment that are available, and I know that there is something, I think, up in Scotland as well, in Johns Hopkins University up in Aberdeen. Now, I've got to have a look and flick through my page, but I've got a list. And I mean, ideally for me, I think NHS England should be looking to, if we're going to change the workforce as we need to, and we do need to. If anybody saw the presentation earlier, you'll know that GP and nurse numbers are going like that. Pharmacist numbers are going up. So if we're actually going to sort of remake that jigsaw to work properly, then we have to make sure that we provide the training that staff need. And I think that therefore that there should be a bit more input from NHS England rather than expecting people to try and do everything off their own bat. I would say have a look at the training that Morph is doing for clinical pharmacy, because they're covering not just clinical skills but also risk management. And I think risk management is a really key thing for anybody going into work in practice. And then I believe as medicines, some of the other companies that provide pharmacists that work in practice also provide some training around the skills needed to go and work in GP surgeries.
Alima, I completely agree with the role you described for CCGs in terms of supporting pharmacists working in practices. Do you think there's another role there in terms of population health? And
Absolutely.
Actually directing basically who you do things to so that you get the best benefit?
One of the things we'd like to look at from the point of view of pharmacists working in community pharmacy is that we'd like to improve the clinical input that they have and sort of move remuneration away from, hey, you've prescribed 83,000 scripts, we'll give you more money, to, hey, you've dispensed so and so many drugs, but you've also looked at, have those patients had their required blood tests? And if they haven't, you've intervened, and therefore we have so and so many fewer admissions to hospital for stroke, for instance, because we've checked that patients are having the correct blood pressure medicines and that their blood pressure is being controlled. So I think there's a huge scope for population-based medicine, but I do feel that it would need the expertise that you've got in CCGs and CSUs to be advising the accountable care organisations that are in the midst of being formed at the moment about which bits of population healthcare are the most appropriate for a given area, because patients aren't all the same, as we know. And so, for instance, in Birmingham, we've got huge issues with diabetes. So we might want our community pharmacists to do a lot more around diabetes, but that sort of advice I can see coming from CCG medicines teams in collaboration with their local public health teams as well, to advise the new commissioning organisations on what they should be commissioning from their local pharmacies.
Thank you, Alima. I think we've run out of time, but Alima will be around on our stand for the rest of today and tomorrow if you want to chat to her. Thank you all for listening.